Just I'm checking out some. Good evening, all. I'm going to discuss the Neet SS recall questions. So, Team RRM with doctorals is discussing all the questions, as you know very well. So, already we have finished cardiothoracic and vascular surgery. Today, I'm going to discuss GIT, HBP, hernia, and transplant. See, there are around 47 questions asked from this section. So, let us have a fast review of all the questions. Corona martis lies near which are the following structures? So, all of you know very well, corona martis is also called as crown of death or circle of death. So corona martis is formed between, so this is a common iliac artery, this is external iliac artery, this is internal iliac artery. This is in the pubic rim. This is internal iliac artery, this is external iliac artery, this is common iliac artery on a laparoscopic view. And from external iliac artery, you know, this is inferior epigastric artery going up. And from internal iliac artery, you know, this is obturator artery going down. So these are the actual anatomy. Sometimes you can have an abnormal artery connecting between inferior epigastric artery and obturator artery. It includes vein also, obturator vein to inferior epigastric vein. At the same time, it can also have an associated artery also. This is called as abnormal obturator. Okay, this is called as abnormal obturator concept. So this is abnormal obturator concept, and this is the accessory obturator vein crosses the pubic rim. That's a direct line from, you can see direct line, pubic rim to connect the obturator and the epigastric vessel, often gives a medial parallel branches called as superior and inferior ramus. This arrangement constitutes a circular connection called as crown of death. See, direct question from Bailey and Law, page number 1095. I have put all the questions reference also. So there is no controversy in the entire discussion. Every question is taken directly from either Sabiston or from Bailey. Okay, so just see the questions. Most of them are from Bailey and Love and Sabiston. Failed POEM procedure. What is the next step in the management? See, POEM has been updated very well in new edition of Sabiston. So next best step in the patient is redo POEM, laparoscopic myotomy with partial fundoplication, medical management, and esophageectomy. And I'm sure all of you would have done correctly. If the pneumatic dilatation was the first step, dysphagia is still present. After repeated dilatation, either POEM or lap Hellas cardiomyotomy can be done. So if the initial treatment was POEM or a pneumatic dilatation, a repeat POEM or laparoscopic Hellas cardiomyotomy should be used depending upon the expertise of the center. So the point here, this is a small controversy here is, I don't know the exact question. When you know the exact question, only you can answer here. Failed POEM procedure, next best step is if the initial treatment was POEM or a pneumatic dilatation, a repeat POEM or lap Hellas cardiomyotomy should be used depending upon the expertise. However, if POEM was performed on the anterior wall of the stomach, a laparoscopic Hellas myotomy may be difficult. Okay, this is very important. So therefore, if a POEM is performed on the anterior wall, a lap Hellas cardiomyotomy may be very difficult. In case of recurrent dysphagia after lap Hellas cardiomyotomy, pneumatic dilatation can alleviate the symptoms. POEM avoids a challenging redo operation because of the presence of adhesions, and the scar tissue can be done safely on the posterior wall of the esophagus. So here, so for a failed laparoscopic Hellas cardiomyotomy, we can do pneumatic dilatation, also POEM. So in fact, POEM is very good because we are doing a dissection on the posterior wall. An esophagectomy should be considered as a last resort only after failure of all other treatment modalities. So here for a failed POEM in this patient, the answers better options here are, it can be answer A or B. Both are acceptable options here. But there should be some more fine tuning in the question, which would have made this question little more specific. See, I'm telling you, don't worry about what is the question asked in the exam, what answer you have made in the exam. Don't worry about any of those things because nothing is going to change now. So now it's the time to focus on how the questions are being asked, from which area the questions are being asked. This is for aspirants who are preparing for Neet SS 2026. Okay, for the next exam, those who are preparing for Neet SS, this will help you. So concentrate on which areas and how to prepare when you are reading Sabiston and Bailey and Law. All these things you should understand from this discussion of 46 questions. Okay, so therefore here you should understand if there is a failed POEM, you can do either a repeat POEM or a lap Hellas cardiomyotomy should be done according to the expertise in the center. Okay. So an elderly male in the ICU develops intractable diarrhea on the second day of admission. So I'm not sure whether it is a second day in the question because lab reveals leukocytosis and thrombocytopenia. What is the most likely organism here is ICU patients will develop Clostridium difficile infection. The question is definitely asking about Clostridium difficile infection, but the point is it usually begins 4 to 9 days after initiation of antibiotics. It usually begins after 4 to 9 days after initiation of antibiotics, but can commence 10 weeks or more also. You can commence 10 weeks also, you can see such patients. So patients presenting with new onset unexplained watery diarrhea. Watery diarrhea, 3 or more unformed stool should have suspicion of Clostridium difficile infection. Patients may also have abdominal pain, fever, and ileus. Patients with CDI may be categorized into asymptomatic colonization, non-severe disease, or severe disease and fulminant disease. Various scores have been used. Leukocytosis of 15,000 cells per ml or serum creatinine of at least 1.4, 1.5. Serum creatinine, this value is typed wrongly here. Serum creatinine of at least 1.5. And there is a criteria for this called as, I hope most of you know the answer, it is Atlas criteria. So Atlas criteria is a simple bedside score to grade the Clostridium difficile enterocolitis. That is based on age, temperature, leukocytosis, albumin, and systemic antibiotic treatment has been used for treatment. Atlas is used for age, temperature, leukocytosis, albumin, and systemic antibiotic treatment. What is the commonest cause of death after bariatric surgery? So this question, therefore, will go for Clostridium difficile. Straightforward question, but small controversies. They have mentioned second day. I feel it should have been 4 to 9 days after the initiation of antibiotics in ICU. Okay. Systemic antibiotics, albumin, systemic antibiotics all form Atlas criteria. Age of the patient, temperature, leukocytosis, albumin, and systemic antibiotic treatment has been used to assess the response to treatment for Clostridium difficile infection. What is the most common cause of death after bariatric surgery? Immediate death. The immediate or early death is due to anastomotic leak, sepsis. Anastomotic leak going for sepsis. But patient here is general overall late causes is usually due to DVT going for pulmonary embolism. So overall it is due to pulmonary embolism is the commonest cause. The answer here is pulmonary embolism. Mortality rates are influenced by the patient selection. Male sex was associated with increased morbidity and mortality in the older series, but not in the most recent experience. This is a very important update in Sabiston new edition. So usually you would have read obesity surgery mortality risk score. In that, male sex will be mentioned. But in new update, in male sex is no more increased morbidity or mortality like in OSMRS score. Those who have read obesity surgery mortality risk score will know this. Almost all studies have identified BMI and history of venous thromboembolism as independent predictors of complication. Okay. So this 75 years old female with a high risk of irreducible rectal prolapse, what is the best management for this case? So very high risk female, that itself gives a treatment. So high risk female, irreducible rectal prolapse. So 75 years female, irreducible, high risk. Naturally, you know the answer. What is the answer for this? Yes, what's the answer for this? Retropubic space of or pubic rim, both are same. What's the correct answer? Yes. Occasionally, patients present with emergency with incarcerated rectal prolapse. Incarceration typically results from obstruction of the venous return from the prolapsed rectum, leading to a bulky edematous rectum that cannot be reduced back into the anal canal. Mucosal ischemia and ulcerations may occur and may progress to full thickness necrosis. Initial conservative management should be aimed at reducing the edema by liberal application of sugar. That's the initial treatment. As an osmotic agent, usually we use max sulfate glycerin oil powder, no, that will mix and put it on the hemorrhoids or prolapsed rectal prolapse. All these things will reduce like that. Sedation, perianal nerve block, or general anesthesia to allow for the attempts to do manual reduction. If a rectal prolapse cannot be reduced, or if there is a rectal necrosis, we have to go for a procedure called as Altimere, proctosigmoidectomy procedure. Answer here is proctosigmoidectomy is the best answer here in this choice. Okay. A patient with a metastatic neuroendocrine tumor presents with profuse watery diarrhea, flushing, occasional wheezing. He is having carcinoid syndrome, diarrhea, flushing, wheezing, asthmatic attacks due to histamine. He has no infective cause and is not responding to antidiarrheal medication. He has no infective cause and not responding to antidiarrheal medication. So what is the most appropriate pharmacology agent for controlling of diarrhea? So no doubt it is lanreotide. Lanreotide is a drug used for controlling diarrhea in a neuroendocrine tumors. There are so many trials on this lanreotide and other long-acting octreotides are used. A new edition of Sabistan has updated a very beautiful table on medical treatment of neuroendocrine tumors. So please remember this table. So the first drug given is somatostatin analogs, maybe octreotide, sandostatin, or long-acting receptors, lanreotide. Streptozotocin for pancreatic neuroendocrine tumor only. mTOR inhibitors like everolimus is being updated. Sunitinib is also used for a pancreatic neuroendocrine tumors. We have only streptozotocin or sunitinib. And lutetium 177 is a new drug, which is a smart bomb. We used to read as smart bomb that can also be used. This is an highly expected serotonin synthesis inhibitor. Tilosprostate, etipretate is also updated in Bailey and Law, sorry, in Sabiston. So please read this new drugs. Used off-label pan-receptor somatostatin agonist or interferon cytotoxic therapy. These are all not used as an approved therapy, but they are used off-label without proper approval. We are using those drugs. Still, there is studies going on, and still investigations are going on with the lutetium dopamine agonists like dopastatin, JS001, and somatostatin drug conjugate. Like these are all new drugs which are under study. Just go through this table. You can get MCQs from this table in the future exams. 65-year male with a diverticular disease presents with a 7 centimeter pelvic abscess and free intraperitoneal air. What is the treatment? So this is Hinch's classification question. A patient having diverticulitis. This is a diverticulitis having an abscess, pericolic and pelvic abscess is grade 1. Pericolic is grade 1. Pelvic abscess is grade 2. A diffuse peritonitis comes under grade 3. And 4 is fecal peritonitis. Fecal peritonitis comes under grade 4. So with the 7 centimeter pelvic abscess is given, free intraperitoneal air is given. This question you have to watch here whether there is any collection in the abdominal cavity. If there is no collection in the abdominal cavity, it comes under Hinchy. As per this question, it comes under Hinchy too. So with these considerations in mind, it is suggested that fit and hemodynamically stable patients be considered for resection with primary anastomosis or laparoscopic lavage in Hinchy 3 perforation and consider primary resection anastomosis with a diverting loop ileostomy for Hinchy 4. So this question is probably given as Hinchy 2 or Hinchy 3. You have to identify because Hinchy 1 and 2 we have to go for percutaneous drainage of abscess and antibiotics, followed by we may or may not do elective colectomy. So definitely we may sometimes there is an update. We can even follow up the patient. If there is sometimes conservatively managed patients can be kept on follow up also. But answer here, if it is Hinchy 1 and 2, you can go for percutaneous drainage. Hinchy 3, you should go for laparoscopic lavage. Hinchy 4, you should go for resection and anastomosis, the loop ileostomy. So don't forget this point. Hartmann's procedure should be reserved for unstable patients or cases where a colostomy could significantly improve quality of life, such as in bedridden patients and those suffering from fecal incontinence. So please remember, Hartmann's is not done for all. It is done only for unstable patients because stable patients, we are doing resection and anastomosis. Unstable patients, we can go for Hartmann's. So these are all to be taken together in this question. So if there is an unstable patient, you may go for Hartmann's. If there is a stable patient, you'll go for resection anastomosis. But if it is only Hinchy 2, you should go only for percutaneous drainage. So this question is completely depending upon every word in the clinical scenario because this is a pure clinical scenario question. So I will tell you in this question, you should learn this is a repeat question. Hinchy 1, Hinchy 2 will be treated by percutaneous drainage. Hinchy 3 will be treated by laparoscopic lavage. Hinchy 4 will be treated by resection, anastomosis, the covering ileostomy. Unstable patients, you have to go for Hartmann's. This is a concept you should carry home at 7th question of Hinchy's classification. This is a straightforward question from Sabiston. A direct line, I always used to tell, questions will be direct line from Sebastian. You should read Sebastian line by line. So during anatomical dissection, which of the following represents the correct sequence of operative steps? This question is as such there in Sebastian a line. Most common approach to anatomical resection, the most common order is mobilization of the liver. First step, mobilize the liver. Dissection of inflow and outflow structures. Dissection of inflow and outflow structures, and inflow control, division by outflow control, and finally go for parenchymal transection. Mobilization of the liver involves division of triangular ligaments, freeing the liver from diaphragm. Often the liver may be mobilized completely of the IVZ, which it straddles, and this requires careful dissection. For major resections, hepatic vein of the resected liver is often encircled before resection. There are various techniques to dissect, control, and divide the vessels. Classical inflow control is by dissection of the hilum with the control of portal vein, hepatic artery to the hemiliver to be resected. So don't forget, this question is directly a line from Sebastian. Mobilization, inflow control, outflow control, demarcation, and resection. That is answer for this question. Which is the most appropriate bariatric procedure in the presence of significant GRD? Significant GRD is present means it's a PG level question. This question is a PG level question. You should never do sleeve gastrectomy, not to be done as sleeve gastrectomy. That's the question. So you will never do lap adjustable gastric bypass also for a GRD patient. Those who are already having GRD, the best treatment is RYGB, because you are making a small pouch and preventing the acid part going into the esophagus like this. Okay, we are going to completely divert the connection and we are going to bring a rule him like this. Therefore, the acid reflex is reduced. Therefore, for a significant patient with a GRD, go for Roux-en-Y gastric bypass as a treatment of choice. Obesity plus GRD, the best surgery is Roux-en-Y gastric bypass. You should never do sleeve gastrectomy. If you do sleeve gastrectomy, that's all. There will be more acid reflexing into the esophagus. Don't do sleeve gastrectomy. Okay. 40-year-old man presents with sudden onset of abdominal pain. On examination, abdomen is soft and non-tender. Abdomen is soft and non-tender. CT shows small bowel wall edema. This is a clutch point. CT scan shows small bowel edema with a mesenteric enhancement with air packets noted. He had dysentery 2 days back, which spontaneously resolved. What is the most likely diagnosis? This is a case of mesenteric vein thrombus. So this mesenteric vein thrombus, one of the important etiology is diarrhea and dehydration. So improper fluid management and dehydration can go for mesenteric vein thrombosis or non-occlusive mesenteric ischemia. Something will happen. So abdominal CT will show you bowel wall edema, and we have to note very important finding. Non-invasive imaging can demonstrate portal vein thrombus, central venous thrombosis. First 5 centimeter of proximal SMV is called as central venous thrombus, peripheral venous thrombus, ascites, and small bowel dilatation, bowel wall thickening, pneumatosis, portal venous gas, and pneumoperitoneum are all findings seen in mesenteric ischemia. So don't forget mesenteric ischemia. It's a simple, straightforward PG level question. Don't forget this question. Okay. A patient with a splenic injury shows segmental devascularization of the hilar vessel. So this is a spleen. So spleen gets multiple types of injury. One of the injuries, this is a multiple small vessels entering into the spleen like this. A splenic artery dividing into multiple small branches. If the main vessel is injured, it is coming under grade 5. If the side vessels are injured, it comes under grade 4. This is grade 5 and this is grade 4. So read the line. So grade 5, any injury in the presence of splenic vascular injury with active bleeding extending beyond the spleen into peritoneum, and in hilar vascular injury which devascularizes the spleen. So the hilum, the vessels get injured is grade 5. Don't forget this question for a lifetime. So hilar vessels injury which leads to devascularization of the spleen. Parenchymal laceration involves segmental or hilar vessels producing more than 25% devascularization. So 25% devascularization due to segmental or hilar vessels. So therefore, if there is a devascularization of around 25%, means this much of spleen has gone for devascularization. It is probably due to hilar vessel injury. So branch vessel injury, devascularization of segmental devascularization. So segmental devascularization comes under grade 4. Completely more than 20, less than 25% devascularization, sorry, more than 25% devascularization comes under grade 4, and grade 5 is shattered or completely devascularized spleen with a complete devascularization of spleen or shattered spleen. That's the answer for this question. Okay. So any doubts? So please post in the queries. Any doubts? Any doubts or any queries, you can post in the chat box. Even if you're attending the recorded version, you post in this chat box any controversy or any question you feel to be corrected. I will correct it during the next discussion. 30-year-old man with a TB taking anti-tuberculous drugs for 2 months. Okay, taking TB drugs for 2 months. Presents with mid-ileal stricture. So TB patient with ileal stricture and a perforation proximal to the stricture. So many questions asked in this exam, I could find out they are not typical exam questions. They are questions which are more like practical questions, which you will do when you are a surgeon. That was the question which was asked more. So mid-ileal stricture with the proximal perforation. He has a viable, healthy bowel. Introp image of the same was given. I could not get the image here, but the introp image of the perforation with the stricture. This is a stricture, this is a proximal bowel. This is a stricture, this is a proximal bowel, this is a stricture of TB. So what is the next management? So no doubt in this, you have to go for a resection of the stricture, including the perforation, and do the anastomosis. So with just primer repair or stricturoplasty is first of all not advised for TB. It is done only for Crohn's disease. But anyhow, for a perforated, even for a Crohn's disease, the perforation will only do resection and anastomosis. Surgical intervention may be required for intestinal tuberculosis, particularly MTB. Obstruction and fistula formation are leading indications of surgery. However, the current treatment, most fistulas will respond to medical management. Surgery may be necessary for complications where there is pre-perforation, perforation with abscess or massive hemorrhage. And in those cases, resection and anastomosis are done is a direct line from Sabiston 22nd edition. Okay. And this question is a very common MCQ topic from very commonly asked MCQ topic from Sabiston on pancreas transplant. True about enteric drainage in a simultaneous pancreas and kidney transplant. So simultaneous pancreas and kidney transplant is done for diabetic patients with nephropathy. So DM with nephropathy who have a uncontrolled diabetes going for CKD, we will do simultaneous pancreas kidney transplant. So usually we do a enteric drainage only. So enteric drainage, how it is done? So pancreas anastomosed, pancreas is like this. This is a donor content. I'm drawing you the donor content like this. This is a donor duodenum with the pancreas. Okay, this is the content I have removed from the donor. Okay, this is the content. Now I'm going to connect this. This one should be connected to the bowel. So pancreas anastomosed with the head of duodenum up. That is very important. And enteric drainage planned after 6 months. That is not done. We will do immediately. The immediate surgery will be done immediately. Donor duodenum suture to recipient bladder. No, we will not do to bladder. There is a separate content called as bladder drainage. And close the duodenum in one layer. No, it is closed in 2 layers. See, direct line. Every line is directly from Sabiston only. So you can see this is a anastomosis of the duodenum to the enteric. And you can see it is head up of the head of the pancreas towards upwards. And this is how you do enteric drainage. And we connect portal vein with IVC and artery to the common iliac artery. The bowel anastomosis between the donor duodenum and recipient jejunum is performed at roughly 30 to 50 centimeter from the ligament of treats. Our convention is to perform 2-layer and Suvan side-to-side anastomosis, not single-layer, 2-layer. That question is also that. There is another question, mesenteric ischemia. That question is also coming up. I had 2 questions from mesenteric ischemia. Okay, one is image-based. So in general, our approach is to implant the pancreas graft on the right side, pancreas on right side, kidney on left side. During simultaneous pancreas kidney transplant, it is also our preference to perform kidney transplant after pancreas is transplanted. First do the pancreas, then do the kidney transplant. Another strategy is to perform kidney transplant portion of SPK operation first. often while a pancreas graft is being prepared on the back table. Although there is no advantage, disadvantage in outcomes with this approach. Okay. So the best answer here is A. So please understand the choices. Pancreas, anastomost, head up with the duodenum, suture to jejunum. That's the answer. So this is again a repeat MCQ in Neet SS. Pan-esophageal pressurization with the preserved peristalsis. In other words, normal peristalsis is present. Normal peristalsis is present. LES pressure is high. LES pressure is high. Pan-esophageal pressurization is present. So don't go on with the MCQ choices only with the POP. So POP is more common in type 2. So that doesn't mean the answer is type 2 here, because here the preserved peristalsis is the point. This flowchart from Chicago version, latest version 4.0 gives the answer. This is from Bailey and Lowe. Chicago version 4.0 says elevated lower esophageal sphincter pressure, IRP, persists in varying positions. Elevated POP, okay, that is called as intrabolus pressure, also called as pan-esophageal pressurization, and abnormal TBO, timed barium image. So in this, if you go back, you go front, you can see 100% absence of peristalsis, you get type 1, type 2, type 3 achalasia. But peristalsis is present, goes to esophagogastric jejunal obstruction. Okay, esophagogastric jejunal obstruction. Jagdish, post poem patient had a hiatus hernia and GRD, means therefore definitely will not go for poem, we'll go only for laparoscopic myotomy. So that's why I'm telling you, if you have a detailed clinical scenario, see this paper is a very good paper in such a way there is no fact-based question, no questions based on values, no controversy being asked. It's all questions are clear-cut clinical scenario question. Every clinical scenario had a line to bring the correct answer. So only if you have the complete clinical scenario, I can give the correct answer. That is why I'm just discussing the entire content. Instead of discussing question answer, I'm discussing the entire concept so that you might be knowing much better what question is being asked than me. Okay. So some of you told atrial fibrillation treated with antiarrhythmic develops acute abdominal pain after 4 days. So this question is different. Atrial fibrillation developed arrhythmia. So previous question is diarrhea developed abdominal pain. So there are two different questions. Atrial fibrillation with an antiarrhythmics developed means he has probably developed a mesenteric embolism. Okay, embolism only will be formed in atrial fibrillation. The left ventricle after neural or myocardial infarction, vegetations on valves associated with endocarditis, all this can form embolus, which can dislodge and cause gangrene. So primary thrombosis, see, SMA embolus is due to some reasons. Atrial fibrillation, vegetations from valves, etc. Primary thrombosis is due to atherosclerosis or vasculitis like TAO or polyarthritis nodosa. This is the first time I'm reading a line showing you primary thrombosis can be seen in TAO also. Please remember, thromboangiitis obliterans also. Primary thrombosis of the superior mesenteric veins may occur in association with portal hypertension, portal pyemia, sickle cell anemia, and in women taking oral contraceptive pills. So there are three different etiology: embolus of the superior mesenteric artery, thrombosis of the superior mesenteric artery, and superior mesenteric vein thrombus. So three cases, but atrial fibrillation is associated with mesenteric arterial embolism. It is a direct line from Bailey and Lowe from vascular surgery concept. Please don't forget this. Ischemic heart disease patient on anticoagulant presents with irreducible inguinal hernia. Ejection fraction is 50%. What is the next step? The patient is on anticoagulant. Patient may be probably on aspirin or clopidogrel. Whatever it is, we cannot wait for the bowel to wait for the factors to become normal. So just do hernioplasty. Sun should never set, sun should never rise in a cases of obstructed hernia. Give low molecular weight heparin and do hernioplasty. That's the answer for this question. So do low molecular weight heparin and do hernioplasty. So approximately 5% of the hernias present as irreducible, painful lump and progress to strangulation and bowel infarction. Time is critical in the presence of ischemic bowel. So open or laparoscopic surgery, both can be done. Approximately 20% of the patients who present as emergency require bowel resection. See, 20% may need bowel resection. This may require conversion of the inguinal incision to laparotomy. Surgical site infection may complicate emergency cases, but unless there is significant infection or contamination, still you can use a mesh. Mesh can be acceptable if there is no significant infection or contamination. That is a very important. Obstructed hernias, can I use a mesh? Yes, you can use a mesh, but you cannot use a mesh in a strangulated hernia or a contaminated bowel opened when you are doing surgery and all. We cannot do, but you have to keep appropriate antibiotics. So a patient presents with answer is low molecular weight heparin and do hernioplasty. Don't do reduction, all those things. We will only do surgery. Patients present with bleeding duodenal ulcer and it is hemodynamically unstable. Attempt at endoscopic hemostasis. 2 times endoscopy failed. So it's an indication of surgery. So during surgery, for a patient who is hemodynamically unstable, we open the duodenum horizontally. Identify the vessel and its branch and ligate it above, below, and medially. 3 sutures will be done. So 3-point ligation, simple suture ligation of the bleeding vessel is a treatment of choice in a hemodynamically unstable patient. If the patient is stable, I will also do vagotomy also. Please remember, in a stable patients, I will also do vagotomy. So hemostasis should be confirmed before duodenal closure. Duodenotomy is closed transversely to avoid narrowing. And surgery for bleeding gastric ulcer typically includes partial gastrectomy with either Billroth 1 or 2 reconstruction. So here we are dealing with the duodenal ulcer. In a gastric ulcer, we should do gastrectomy partially. So patient is hemodynamically stable. This question is a catch point for Neet SS. A careful preoperative history should assess the patients may benefit from concurrent truncal vagotomy. Though this can be performed, should not be performed in unstable patients. In a stable patient, you can do. So if a gastric ulcer is not resected due to some unstable patients, we have to take biopsy to exclude malignancy from a gastric ulcer is essential. That is for 17th question. So answer is simple suture ligation and bleeding of unbleeding vessel. We don't do antrectomy or truncal vagotomy now. We don't do antrectomy or truncal vagotomy for a bleeding duodenal ulcer. That's about the 17th question. 18th question. A patient presented with esophageal mass, smooth wall, no mucosal integrity, and hypoechoic on ultrasound. Diagnosis is over. This is a neat PG question. Hypoechoic on ultrasound, EUS ultrasound is a clear-cut case of leiomyoma. So EUS shows the lesion arising from 4th layer, more commonly than 2nd layer. So 4th layer is muscularis layer. So we should do EUS is an investigation of choice. Don't do biopsy, because when you do biopsy, you cannot do enucleation treatment, because enucleation is a treatment of choice. Don't do biopsy, just confirm it with the endoscopic ultrasound and plan for enucleation. So you can easily do for smaller lesions by endoscopy itself. For lesions more than 5 centimeter, you should go for wax enucleation. These are all repeat NEET PG level questions. Don't forget 18th question. So this is a Neet SS question. Which structure marks the transition of middle to lower thoracic esophagus? See, we have 4 parts of esophagus. Cervical esophagus is from 15 to 20 centimeter. This is cervical esophagus. 15 to 20 centimeter is cervical esophagus. 20 to 25 is upper thoracic. How to know upper thoracic and middle thoracic? The junction is azygous vein. Azygous vein is a landmark on CT scan. On a CT scan, I will say azygous vein is a landmark between upper thoracic and middle thoracic. And between middle thoracic and lower thoracic, I have the inferior pulmonary vein. So inferior pulmonary vein is for 25 to 30 centimeter, 30 to 40 centimeter. The vessel is, so azygous vein is one landmark on CT. Inferior pulmonary vein is another landmark on CT. So don't forget these 2 landmarks. So upper and middle azygous, middle and lower inferior pulmonary vein. They're asking middle to lower. The answer is inferior pulmonary vein. So please remember the answer for middle pulmonary vein is answer for middle to lower. The answer here is B, inferior pulmonary vein. So upper and middle, it is azygous vein. Middle and lower is inferior pulmonary vein. So the answer here for middle to lower thoracic esophagus is the inferior pulmonary vein. The most important point, this is a repeat question. This is a repeat Neet SS question. Already this question is asked. They asked in previous year question upper and middle, that is azygous vein. So don't forget this question. Type of hernia which has an inflamed appendix. Type of hernia with inflamed appendix is Ameyand. No doubt in that. Litter is Meckel's. Okay. Which of the following is not a treatment strategy for chylothorax? A paragraph question directly from Sabiston, page number 1755. If you have a doubt, you can go to that page. Everything is directly taken from here. Which is not an infection strategy. I mean, there is no such treatment called as bypass. There is no such treatment. Okay, please remember. A patient who underwent esophagectomy having a thoracic drain. Now, suddenly the drain shows pink color fluid initially, and once the patient starts oral diet, it becomes a milky white fluid. I will confirm it is chylothorax by taking triglyceride level is more than 110. So triglyceride level is more than 110. That is a clue. Initially, I will do simple. If there is no ICD tube, put an intercostal tube and start them on medium chain triglyceride therapy, which are not absorbed through lymphatics. Medium chain triglycerides will directly enter into venous circulation instead of going to drain via lymphatics. That is the concept of medium chain triglycerides. Parenteral nutrition, octreotide or somatostatin is given. For patients with a thoracic duct injury and an effusion persists after 1 week of treatment with appropriate diet, etc., should be considered to identify and occlude the thoracic duct above and below the leak. The approach has been done by VATS or thoracotomy. So mass ligation will be done at the level of hilum N3 between aorta and vertebra level. We make a mass ligation between the esophagus, aorta, and vertebra level in cases of unidentified leak. But if you identify the leak on VATS, go and suture the leak or clip the leak above and below. However, a new endoluminal technique has been introduced and is becoming optimal first approach. So endoluminal technique, what is this new endoluminal technique? This is done with lymphangiography, usually through a groin lymph node access to identify the location and anatomy of cisterna chyli and the location of divided thoracic duct. Once cisterna chyli is opacified, it is percutaneously assessed with a spinal needle through cisterna chyli, entered through a spinal needle using a radiographic guidance and is catheterized. The location of the divided thoracic duct is identified and repeated lymphangiography and duct is embolized. So embolization of thoracic duct is a new update. This has a success of 50%. So for patients with cancer-related chylothorax and persistent drainage, despite chemotherapy and radiotherapy, fluorodialysis is highly successful in preventing recurrence. So fluorodialysis also can be done. What is not done? Bypass is not done. Embolization. So new updates are embolization is a new update, management, and another update is fluorodialysis. So these are the two updates in the management of chylothorax. Please remember this question. So 22nd question, I don't know what is the exact line they asked, but patient underwent cytoreductive surgery for pseudomyxoma pneumoniae. What is the next step? See, after cytoreductive surgery, the concept is after cytoreductive surgery, immediately we do HIPEC, hyperthermic intraperitoneal chemotherapy. So that is a common procedure. That is called as sugar beta type. We do surgery and HIPEC. This approach combines multiple peritonectomy, visceral resection, and after that, we will give a mitomycin or oxaliplatin will be poured into the abdominal cavity, and we will wait for 10 hours. It's a 10 hours plus procedure. 10 hours plus the chemotherapy will be directly acting on the abdominal organs. So following a complete cytoreduction operation, 5 to 10 year survival rate is 87 to 70%. So poor outcomes are seen in male patients, elevated tumor markers, and high-grade or invasive features. Follow-up essential up to at least 10 years because recurrence is a major issue in cytoreductive surgery. So don't forget this question. Okay, so that's the 22nd question. What is the management of these patients? Patient underwent laparoscopic cholecystectomy for gallstones. Histopathological examination shows localized carcinoma limited to lamina propria. What is the next best step in this case? Next best step. Laparoscopic cholecystectomy for gallstones. Histopathological shows, this is a simple question. T1A, lamina propria. T1B, muscle layer. T2, perimuscular connective tissue. So these are the incidental specimens like lamina propria, muscularis, muscle layer, and finally perimuscular connective tissue. So see, when you're getting these findings in a post-op specimen, so lamina propria, lab cholecystectomy is enough. In T1B, extended cholecystectomy is needed if there is a high-risk case. Means margin positive, poorly differentiated. We go for extended cholecystectomy of 2 centimeter liver resection. Very muscular involvement, we have to go for a radical cholecystectomy. So here the question is lamina propria only. So observe and follow up is the answer for this question. The likelihood of nodal disease in this setting is less than 3%, and cholecystectomy cures 85 to 90, 100% patients. Only thing you should do is we should look for cystic duct margin. If it is negative, nothing to worry. Okay, that's all. It's a NEET PG question. See, 23rd question, 24th question, all are NEET PG questions. I don't know why they ask NEET PG question to NEET SS level. Which is the artery relied on blood supply using a gastric conduit for a esophagectomy. So I am going to use gastric conduit based on this artery. I am going to reconstruct the esophagus by using this greater curvature of stomach like this. So this is based on right gastroepibloic artery. Simple, straightforward question. Right gastroepibloic artery is a gastric conduit. So which of the following is a preferred step during surgery for a strangulated? See, the question is asking about strangulated. Strangulated means it is obstructed and gangrenous. What should I do for an obstructed and strangulated hernia? So assume this is a strangulated hernia containing the bowel inside. See, this is a practical question. I'm telling you, many practical questions are asked. So this will be having full of toxic fluids. There are many choices like remove toxic fluid. All those are funny choices. Other choices are not even expected. The toxic fluid is another choice. So see, now the point is this is a constriction ring. Okay, this is a constriction ring. And this is full of toxic fluid. So now what should I do next? The question is asking which of the following is a preferred step. So never ever forget, we will not go and open the neck first. This is a practical question. If I open the neck first, what will happen? The bowel will get reduced and some gangrenous bowel will go inside. So always open this part and look for explore the gangrene. Then only you should release the neck. So what is done first means open the sac first before dissection at the neck. So don't dissect the neck first. If you release the constriction, the bowel will go inside. And there are cases like Madel's hernia. I hope you all know Madel's hernia. If I release the constriction, some bowel which is present inside may be gangrenous already. So always explore the contents. First see the contents, then you open the neck. So see the contents. Sometimes we may leave the toxic fluid also when we are opening the sac. We will let out the toxic fluid also only by opening the sac, not by tapping with the needle or etc. So open the sac first. That is answer for 25th question. So 26th question is also a repeat NEET SS question. What is called as Achilles heel of liver transplant? In liver transplant, there are 4 anastomoses done. So first anastomosis will be IVC to IVC. Second anastomosis will be, yes, what is second anastomosis? Portal vein to portal vein. Third anastomosis will be hepatic artery to hepatic artery. And finally, the last anastomosis is bile duct to bile duct. So this is the order of anastomosis. So reperfusion syndrome happens during portal vein reconstruction. The major point is due to morbidity involved with biliary complications, bile duct anastomosis is considered to be the Achilles heel of liver transplant. So management of bile leaks usually involves bile reconstruction with the Roux-en-Y hepatic jejunostomy in the immediate post-transplant period, or we may need a stenting also sometimes. So Achilles heel is biliary complication and biliary leak. Post-bariatric surgery, diabetes control is mediated by which of the following? So glucagon-like peptide 1, GLP-1. So GLP-1 is the one which is control of type 2 diabetes involves with the improves weight loss owing to improvement in insulin resistance. Remarkably, diabetes control appears to improve after several types of bariatric surgery, even before the meaningful weight loss occurs. This is a very important line. Even before the weight loss happens, diabetic control starts first. Diabetic control appears to start before even weight loss. Some of the effects on glucose metabolism can be attributed to the caloric restriction, but changes in the gut hormones like glucagon-like peptide. So GLP is an incretin, a gut hormone that stimulates the beta cells in the pancreas to restore the normal first phase insulin response after eating. So GLP-1 is the answer for this case. This question is GLP-1 related question. Okay. No doubt, whatever the question will be, the answer is GLP-1 only here for diabetes control. A patient presented with dysphagia to solid foods but is tolerating liquids. He is unable to eat solids but tolerating liquids. Endoscopy shows cancer of the esophagus. Now, CT shows aortic angle contact more than 90 degrees. So, this is a classical stage of T4A is removable structures. T4B is unresectable. So, a cancer which is T4B is unresectable involves aorta more than 90 degree, vertebra, tracheobronchial, all these things are unresectable. Unresectable, go for a definitive chemoradiotherapy. T4A, we go for neoadjuvant chemo RT followed by surgery. But for unresectable, definitive chemo RT is done. No doubt in that. It's a straightforward question directly from a paragraph from Sabiston, page number 115. 1145, you can see that. 40-year female presented with right upper abdominal pain, ultrasound showing 2 centimeter polyp. I'm sure you all would have had no doubt in this. Answer is laparoscopic cholecystectomy only. So we have to go for laparoscopic cholecystectomy for this case because this polyp itself is 2 centimeter and polyp with the stone is another indication. I have put the table as such from Bailey and Lowe. Large 3 centimeter stones. See, the question is updated 3 centimeter, not 2.5 centimeter. Polyp 1 centimeter. Hemolytic anemias, CBD stones, risk of malignancy, calcification, North India people, transplant patients, and bariatric surgery cases. These cases we have to do laparoscopic cholecystectomy. Okay. A patient underwent laparoscopic abdominoperineal resection shows multiple enlarged nodes along the IMA. Where is the IMA ligated? So this question is a classical question. Again, another controversy. I'm not sure with the choices what you had in the question paper. So this is inferior mesenteric artery. It gives the first branch left colic artery. This is left colic artery. So then it gives sigmoid arteries, etc. And then gives finally end as superior rectal artery and sigmoid arteries. So the question is, very commonly we ligate it high ligation at the level of origin. This is where we ligate because we will have nodes in these places. This is a concept. So high ligation of IMA is a concept. The problem happened is when we do high ligation, the hypogastric plexus, superior hypogastric plexus can get injured. So people started doing ligation after the first branch like this. After leaving the left colic artery, people started ligating here. This is a first branch after the first branch. But this is the old concept. But new Sabiston has very clearly told high ligation of IMA proximal to the take of left colic artery is performed by many centers to allow clearance for all original nodes. Our current evidence has not conclusively shown improved outcome when compared to the ligation at the origin of a superior rectal artery just distal to the takeoff of left colic artery, which can reduce the risk of injury to autonomic nerves. So from this line, I will say, since there are more loco-regional nodes, we'll go for flush ligation of IMA at the origin will be the better answer. But this is again depends upon the choices you had in the exam. 30th question. 55-year-old male with a painless jaundice and palpable gallbladder. So palpable gallbladder is always Courvoisier law. As per Courvoisier law, palpable gallbladder is seen for distal bile duct, head of pancreas, periampullary cancer. That's all. Only for 3 cancers you have a palpable gallbladder with a painless jaundice. So yes, CA head of pancreas may have pain, especially back pain, but what to do? There is no other better option here. Merici syndrome, choledocholithiasis, CAGD, all of them will have pain. Only fellow who may not have a pain is periampullary cancer should be the best answer. So therefore go for a CA head of pancreas, which was there in this choice. A male patient with a progressive dysphagia, weight loss, has a history of corrosive injection 15 years ago. This question is just to mislead you. Corrosive injection 50 years ago, Barrett's esophagus, alcohol abuse, and a 10-pack cigarette. What is the most significant risk factor of adenocancer? See, for adenocancer, there is only one risk factor is here, that is Barrett's. If they have asked squamous cell cancer, I would have gone for smoking, corrosive injection, etc. But for adenocancer, see the picture. So adenocancer risk is smoking is one risk factor. Radiotherapy given as risk factor. obesity, GRD, and Barrett's is a risk factor. This is a table question from Bailey and Law. It's a simple question from Bailey and Law, a straightforward question. Okay, it's straightforward a question from Bailey and Law. So the answer is Barrett's esophagus, and it is a neat PG level question. Many questions are neat PG questions. I was wondering why they have asked so very basic questions, which are PG level, not even like a super specialty level. See, calculation of child Turcot score, child book Turcot score and all is very basic question. Bilirubin of 3.6 means 3 points. Ascites controlled with diuretics means 2 points. INR 1.6 is normal. Albumin 3.8 is normal and no NCAF of this. So I will give 1 point, 1 point, 1 point for all of them. So child B 8 points is the answer for this question. Child B 8 points. So this bilirubin is given in milligrams per deciliter in Indian books. Milligrams per deciliter is 1 point is given for less than 1 milligrams. 1 to 2 milligrams per deciliter, 2 points. More than 2 milligrams per deciliter is 3 points. That is the value from Indian books. Okay. Just remember this values from various books will change, but here it is 3.6 is definitely more than 3 points. It is given 3 points. So and I heard 2 questions were from gastric volvulus. I don't know whether they both are same question or 2 different questions. And you know very well, gastric volvulus is a favorite exam question. Every year there will be a question on gastric volvulus. This volvulus can happen in this direction. Organoaxial is most common. 80% of the cases it is organoaxial, and it is usually associated with congenital diaphragmatic hernia. And they have a triad called as Borchardt triad. So retching pain, unable to vomit, and unable to pass Rayleigh tube. Unable to pass Rayleigh tube. So these are the 3 features of this organoaxial volvulus. Unable to vomit, unable to pass Rayleigh tube, and pain. All these are organic axial volvulus. And this picture is very clearly showing you an organoaxial volvulus. There is another volvulus very rare, which will be in this direction. But it is very rare. Mesentericoaxial is very rare, but here the picture is organoaxial volvulus. This is a picture of organoaxial volvulus, and this is an X-ray showing you organoaxial volvulus. So all these are 3 pictures of organoaxial volvulus. So whatever the question, now the very important update in new edition Bailey is, new edition Sabiston, the most important update is what is done next? Because many years we were discussing on immediate surgery. Now the first step in the management is to pass a nasogastric tube. With so much of difficulty, we should try to pass. This, when you pass the Rayleigh tube into the stomach, this can convert an emergency operation to an elective operation, which can be performed after 24 hours. And this facilitates hernia reduction and repair of a decompressed tissue, allowing resuscitation. So pass the Rayleigh tube. If Rayleigh tube is difficult to pass, go for a nasogastric tube. Cannot be passed, go for an endoscopic reduction. So first Rayleigh tube, second endoscopy. Okay, try to do endoscopically. If that is also unsuccessful, then only go for third step is surgery. This is a new update for volvulus. Rayleigh tube, endoscopy, surgery. Okay. Young female with a recurrent cholangitis, MRCP shows a fusiform dilatation of bile duct, type 1 choledochal cyst. What is the treatment? So no doubt it's a PG level question. We should resect the cyst and do a hepaticojejunostomy. So type 1 cyst should be resected and do hepaticojejunostomy because of the risk of cholangiocarcinoma in this cyst. Cholangiocancers can happen in this cyst. Therefore, you should resect it and do a hepaticojejunostomy. So same other question was there. Type 3 choledochal cyst, very important. Type 3 choledochal cyst is the rarest of all the choledochal cysts. It does not have anomalous pancreatic bile duct junction. So no risk of cancer. So please understand, rarest, no anomalous pancreatic bile duct junction. There is no risk of cancer in type 3 choledochal cyst. Therefore, just to do sphincteroplasty is enough. Endoscopic drainage and sphincteroplasty is enough. So for a transduodenal excision and sphincteroplasty can be enough for type 3 choledochal cyst. So here answer is ERCP and sphincterotomy A. Which of the following criteria are considered unresectable for cancer of head of pancreas? See, understand, abutment means less than 180 degree. Encasement means more than one. This wording you should not forget. Abutment means less than 180 degree. Encasement means more than 180 degree as per NCCN guidelines. As per NCCN guidelines. So unresectable is encasement of superior mesenteric artery more than 180 degree or celiac artery encasement. See this line. So NCCN locally advanced superior mesenteric vein and portal vein in an unreconstructable manner. SMA encasement, celiac artery encasement, common hepatic artery encasement. So encasement in three arteries, SMA, celiac artery, common hepatic artery, is said to be locally advancement. If the three are abutment, then we call it as borderline resectable. Okay, so borderline resectable is abutment. SMV or portal vein abutment less than 180 degree with contour irregularity or thrombosis. Contour irregularity or thrombosis is borderline resectable. And no abutment or involvement less than 180 degree with contact without contour irregularity all comes under resectable. Okay, so just remember this unresectable. Very commonly they ask you unresectable option. Yes. Patient with Los Angeles grade D means more than 75% lumen having erosions and 3.5 centimeter hiatus hernia with a normal motility study. That's a catch point here. If there is a normal motility only, we will do Nissen fundoplication. If there is ineffective motility, we will do Taupe fundoplication. So good motility, Taupe, Nissen. Some ineffective motility means you will go for Taupe. So the answer here is Nissen. Los Angeles case with the hiatus hernia, best answer here is Nissen's. Incomplete symptom control with medical management is one of the indication of surgery. Intolerance to comply with long-term medicines. Regurgitation despite medication. Presence of large hiatus hernia. Complications from GORD. These are the indications, extraesophageal symptoms. Predictors of good outcomes include PPA responders, hiatus hernia, grade B and above esophagitis, non-dysplastic Barrett's. Poor outcome will be seen with normal pH, EGO obstruction, functional heartburn, connective tissue disorder, and extreme obesity will have poor outcome. This paragraph is a repeat question from Alien Law. Please remember this paragraph. It's a repeat question for Neet PG as well as Neet SS. Okay, don't forget. That is a pubic crest and retropubic space. Two options are there. Okay, so it is actually the pubic rim. Actually, the line from Alien Law is mentioning about pubic rim. So better go for retropubic space only. That is the correct answer. Pubic rim is retropubic space. Which of the following are the IHC markers of GIST? So clear-cut, straightforward question. CD017, PDGFRA, CD34. Pathologically, GIST can have a spindle cell or epithelioid appearance. CD017, DOG1, CD34, PDGFRA are the tumor markers of GIST, which is not an indication of Barrett surgery. So absolute contraindications are. Absolute contraindication include Prader-Willi syndrome. Prader-Willi syndrome and psychiatry patients. They are the patients whom we should never do bariatric surgery. It's a PG level question. So BMI above 40 or 35 with comorbidities or 30 with uncontrolled diabetes. They all directly from Valiant Law. BMI above 40, 35 with the diabetes for more than 10 years, 30 to 35 with the diabetes within 10 years. And the Asians, you can reduce the value. And for above 50, super obese, it is a treatment of choice. So it's a treatment of choices for super obese, more than 50. So beautiful question from esophageal foreign body. A patient came to emergency room with the emergency room with the foreign body in the esophagus. How will the foreign body look? That is the question. So in an AP view, this is a AP view. How does it look? The coin looks in classical coronal plane. So don't forget, the coin looks in coronal plane. So this is coronal plane. See, what is coronal plane? See, this is a coronal plane. If the patient, this plane is coronal plane and this plane is sagittal plane. If we see lateral view of the coin is sagittal, AP view of the coin is coronal. So AP cut, you cut it like your body like this. It's called as coronal. If you cut it sagittally, lateral view. So therefore, the coin in a esophagus looks like a Coin seen in coronal plane on AP view. Looks like in a coronal plane means like O in an AP view. And coin is seen anterior to trachea wrong. It is always seen posterior to trachea. See, esophagus is seen posterior to trachea. So therefore, you'll see posteriorly like this. So that is also wrong. Sagittal plane AP view is also wrong. This is simple MBBS level question. So don't forget this question. I used to remember esophagus looks like O in AP view. That is one point you should not forget. Esophageal coin looks like O in AP view. A 2-year boy is brought by his mother when she incidentally noticed a groin swelling. While bathing a child, on inspection, no swelling is seen. See, when she incidentally noted a groin swelling while bathing the child, on inspection, no swelling is seen. On examiner, traps the testis into the scrotum and then notices a inguinal swelling. So what is associated? Undescended testis will be associated with indirect hernia is a golden rule. Everyone know that. So all of you would have operated undescended testis. You will also do herniatomy in all those patients. Answer is A. Post-cholecystectomy patient presented with jaundice and features of cholangitis. MRCP shows filling defect in the lower CBD. So I am planning to do a stone here. I'm planning to do a ERCP. What preoperative investigation is most important before proceeding to this procedure? What is the most important procedure that should be done before proceeding? That is nothing but PTINR. We have to correct prothrombin time INR because patient is in obstructive jaundice. Therefore, there will be bile salt decrease, and bile salt decreases, vitamin K decreases, and that results in 2, 7, 9, 10 decreases, and it involves elevated prothrombin time and INR. Therefore, correct this by giving vitamin K or by giving fresh frozen plasma. Either you correct it by vitamin K or by fresh frozen plasma. Okay, so these are the points you should not forget. So leave about that question. Corona Martis, leave out. Don't worry about that question. See, better answer is retropubic space only. Among these options, better option is retropubic space only. Corona Martis is seen in retropubic space. Is a better answer because it is exactly the abnormal obturator artery runs between inferior epigastric artery and obturator artery, which is seen in the retropubic space only. So leave that question. After lap adjustable gastric banding, patient presents with worsening symptoms. Imaging shows the band is in vertical position. See, usually when you put a band in X-ray, it will be seen horizontally. If it is seen vertically like this, it is gone for displacement. So the band got displacement. The band is initially placed with the addition of saline to distend it. Saline is added in 1 to 1.5 ml to produce desired weight loss of 1 to 2 kg per week. Excess weight loss may lead to removal of saline. Incidence of nutritional deficiencies is low in lap adjustable gastric banding. Slippage of lap band can result in acute strangulation. It's a necessary emergency. Surgical removal of the band is very important. Surgical removal of the band, but is more likely to present with symptoms of dysphagia, regurgitation, heartburn, and aspiration. Though they don't develop strangulation, but they have dysphagia, regurgitation, something. So plain radiograph will show you normally located at 7 o'clock to 2 o'clock. So the band will be located like this. This will be the normal location. So if it becomes horizontally or vertically, it means what? This band is displaced. We have to remove it. So we have to surgically remove the band. No doubt in that. Obesity is not associated with hyperthyroidism or Graves' disease. They have weight loss. That's a classical question. Hyperthyroidism, diabetes, PCOS will have obesity. So identify the histopathological slide. See, we have found out very easy question. Histopathological slide shows squamous cell cancer of the anal canal. So this is called as keratin PL formation in squamous cell cancer. So these are the 47 questions I could recollect from my topic of GIT, HBP, hernia, and transplant. So these are the questions I could recollect. And other faculties are doing, corresponding faculties are doing all the recalls. We have collected all the questions. So complete recall is going on to happen. Don't worry. So because we wanted to do a perfect recall, we don't want to do just like the namesake recall, just to guess answers and all. We don't want to make that. That's why we took some enough time to find out the exact references from the book. So cardiothoracic surgery completed, vascular surgery completed, and I have completed GIT, HBP completed. Soon you will be having urology, plastic, vascular, neuro, So I asked the corresponding faculties to discuss, so it may take some time because they're also working on the questions. Urology, plastic, neuro. There is also discussion by oncosurgeon on breast and other things. Oncosurgeons, two surgeons are going to discuss on their corresponding topics. So totally around 10 faculties, including general surgery and trauma, will be discussed by Dr. Pradeep. So all these faculties will be discussing within 1 week maximum. They will finish up in 1 week. So please go through our recalls in this same YouTube channel. We'll be having the recall, and these videos will be available in our app. So Dr. Drill's app will be available, and we are in the process of recording for new version of the Sabiston 22nd edition and Bailey and Love 28th edition. We are recording, so the new videos are going to come. So if you're already a subscriber, you'll get the new videos definitely. So if you have any doubts, don't hesitate. You post in this same chat box itself. I'll try to reply in the same chat box. Or if you have a doubt, you can post in our WhatsApp group also. There also we can discuss. Immunocompromised like picture is patient is mentioned. Cytomegalovirus will not just like that happen. So for a cytomegalovirus to happen, the question should definitely have a transplant patient or an patient on immunosuppressant. Something should be there. Then only we can think of CMV colitis. Otherwise, the question was mentioning more of leukocytosis and other concepts more to Clostridium difficult because it's a patient in ICU. That's a direct lining for Clostridium. Patient in ICU on antibiotics. So this is in this commerce question, anal canal cancer in the patient was given and 4 slides were out of which we selected. That's that. Thank you. So I will change it. So therefore, they have given 4 slides. Okay, it's more like a pathology question. So I think the only question given was anal squamous cell cancer was given, and you have given 4 slides, and you have to select this keratin. Thank you so much. 6 years old male, protruding verge with the perianal itching. Thank you. That is a classical squamous cell cancer with the keratin pearl appearance. That's correct. So any other doubts you have, please post in the chat box. I'll be explaining them in the chat box itself. Or you can post in our WhatsApp groups. You are all there already in the WhatsApp group. So you can, if you're not there in the WhatsApp group, please join in our Telegram channel also. This is our Telegram channel. Please go join this Telegram channel. So all the SS aspirants presently in the country, all are there in this channel only. Thank you. Any doubts, you can post here.